Good morning, everyone. How are you? Everyone doing okay? I really appreciated your talk, Dr. Magnana. Is that right? Dr. Jean. And a lot of what I'll be talking about is very much aligned with what you've said as far as really trying to get an interdisciplinary team involved in caring for children and families with chronic illness. And also making sure that the psychiatric care is there for those families, the children and families. Um, so, so my name is Kim Amer, and I did my doctorate in 1997 and have been teaching since then. And I've published a couple articles about how children perceive themselves when they have a chronic illness. And most commonly, I've looked at type 1 diabetes as a challenge that the child goes through. And so what I'm going to share is the children's perceptions of their illness and also how to apply a risk and resistance framework when you're looking at them clinically, but also you can use it for research. So what I observed in my practice is that there were certain children and families who did very well when they were first diagnosed with type 1 diabetes. And conversely, there were other families that had a lot of resources. They may have been affluent with a lot of community support, but they did not do well. They came in several times during the first year with diabetic ketoacidosis and were very, very ill. So this was baffling to me, and I really wanted to kind of deconstruct exactly what was going on. So I explored this concept for my dissertation and found that it was actually very messy. It was not, there wasn't a straightforward, this attribute predicts, compliance or very, very good outcomes. And actually, when we began to find that glycosylated hemoglobins really were a good way to track how children with diabetes were doing, that was just one measure. The physiologic measure of long-term blood glucose control was helpful, but it didn't really get down to the heart of everything else that's going on. So, this is just a little bit of my background. So I spent about 7 years working in pediatric endocrine. I already talked about the diabetes, and the two families that really made me most curious about what the predictors were one family that was the father was a pastor in a suburban area in Chicago, outside of Chicago, and Sarah, their 8-year-old daughter. The names have been changed to protect their identities. 8-year-old was diagnosed with type 1 diabetes. We spent a week doing education with her and her family, and she was hospitalized 3 times during that first year with diabetic ketoacidosis. And her blood glucoses were above 800 milligrams per deciliter, and she was also very severely acidotic. Conversely, there was a 9-month-old infant who was diagnosed with type 1 diabetes, and that was the youngest that I had ever worked with. And Danielle was a wonderful infant with a really good temperament, but I worried because the mother was single, and she also had a 5-year-old that she was caring for, and she had to find daycare for this, for Danielle. And Danielle, and the doctors wanted Danielle to actually have twice a day glucose monitoring. So back then, people were very nervous. This was in the late 90s, very nervous about contracting AIDS or HIV from blood. So the daycare centers, I had to go talk to them and convince them to allow her to be tested at daycare. So the number one, you feel like the first case has very few risk factors for not doing well. I feel like there's a lot of resistance factors versus Danielle, who actually, the mother was extremely vigilant and did a wonderful job. And Danielle had very normal glycosylated hemoglobins. So then I continued to try to figure out in my research mind, and I went to several conferences to look for some of the predictors. So the question made me really dig into the literature to see, okay, what is going on here? What are the things that can help or hurt? What can I do as a nurse to really make sure that they're successful? And I came across a lot of different disciplines. So the multidisciplinary approach to any child with a chronic illness is really important. And I really think that the psychological well-being of the child and family should be assessed right at the diagnosis time. And so if you have an assessment and develop a relationship with a psychological support person, that will make it a lot easier for parents and kids to kind of go back to that person and continue, if they're in a crisis or they're having challenging times with various developmental levels, that would be a good way to go. So the messiness is that there are psychological, social, I don't know if I can actually point with this, but you can see social, spiritual, educational, financial status, and perception of chronic illness. And then, of course, as Jean said, if parents are struggling with their marriage or their partnership and they become divorced, that's a huge additional stress. So most studies, when I looked into the literature, actually explored how teachers or nurses or doctors or the actual parents perceived the illness. They really didn't ask the children how they were doing or how they were feeling. So that was part of what I wanted to look at. So I was at a conference in Cleveland, Ohio, in the United States, and I was talking to a well-known researcher, Denny Drotar, and he, talking about kind of where I was at and how in the fog I was as far as trying to sort out everything. And he said, "Oh, look at Jan Wallander's risk and resistance model." And so that really helped me put things into more of a categorical organizational chart. And then Jan Wallander's model is something that if you research kids with chronic illness, or if you're just if you're practicing with kids with chronic illness, it really allows you to assess them in a very holistic manner. So this is part of Jan Wallander's risk and resistance model, and basically the type of diagnosis is an important factor. So the biggest factor with the type of diagnosis is it visible? So as we know, kids tease each other about everything, right? You got glasses, you limp, or you may have some disfigurement, and it may be minor, but children are really bad about teasing each other about just the most minor physical differences. So if it's not visible, like diabetes, or in most cases seizures, if you are well managed and you don't have a seizure on the playground, then those are the kind of things. How severe it is, if there's impaired cognitive function. So that's either, you can see these as either risk factors or also resistance factors, right? So each factor, like the diagnosis, if it's visible, may be a risk factor. If it's not visible, that might be a resistance factor. Does that make sense to everyone? No? Yeah, okay. And then how much they're able to do on their own. I don't know if any of you were able to watch the Special Olympics in Paris, but it was amazing to me that I used to be on a swim team, people who were swimming without arms and competing, or even, or they had arms and no legs, and they were like so resilient and driven. So, they some were independent and some were actually dependent on people wheeling them into the pool. But that functional independence is either a risk or resistance factor, but most of it is really about how you perceive your illness or your functionings. And then mental social, the kind of the outcomes are how well adjusted you are. So do you have marital stability, social and physical stability? Okay. And then the biggest thing is really how you process stress, right? So Lazarus and Folkman back in the 60s talked about that there's really very much difference from person to person as far as how they perceive stress. And I think my husband and I are a great example of that. If we're stuck in traffic, I'll be like, okay, I got to file this nail. No big deal. It's kind of been bugging me. And he just gets like, you can see his blood pressure just go up, 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 up. So that's a great example of really anyone, if the perception is that this disease, diabetes, is going to be overwhelming, their life is going to be just rocked by it and nothing's going to ever be the same, then that really puts them at risk for not doing well. So that appraisal is important. And then, of course, children with personal factors that are difficult temperament-wise, if they have some conduct disorder or ADHD, that may make it more complicated. And then the social ecological factors. So there are tons of things here, right, that really combine to determine how well someone's going to do. And then these are additional risk and resistance factors. And I think I hit on most of them, but the outcomes are how healthy they are psychologically and physically, and then life satisfaction, and then ultimately, as they get older, marital adjustment. And there's also a relatively new child quality of life measure. So I'll get into that in a second. How much time I have? So the most significant factors are that they're complex, they're intertwined. It's really difficult to pull one out. They're all kind of all meshed together. But it is important to try, as clinicians, to try to really assess all the levels that are really going to influence how the child and the family does. And I think if you can see, for example, low educational level, low income, low social support is going to be really making it tough for managing the chronic illness. Poor coping strategies, or if you're like Eeyore, do we have any Winnie the Pooh fans? Just one? Really? Do you guys know who Winnie the Pooh is? Yeah, okay. Yeah, so Eeyore's the one who's always like, so if there's a family that just feels like this is horrible, it's tragic, how am I gonna do this? That's gonna not be a good indicator. And so the other thing that I came across that I kind of didn't even realize is that we as healthcare providers are social support for the families. And I really didn't think about that so much because I was like, oh, I'm an educator, but even though sometimes I talk to them every day when the child was sick, I didn't think so much of myself as a support, but actually that's one of the main things we can do. And so what we want to do is really foster resilience and then what I did from here, I'm not sure if I can get rid of this thing. That's Sherry. Okay. Anyway, this is a model that I developed, and basically stress is raining down on the stress of chronic illness. Okay, so we all know that anyone with a chronic illness is going to have stress. So here are the coping strategies that really filter through with almost everything. So once again, how you're going to respond to the illness is all related to your coping. A lot of coping with parents and children are really determined by how those before them coped. Okay, so there's a lot of modeling from parents or maybe teachers. And so I apologize for the quality of this not being so great, but on the white area outside the circle are all the family factors that may affect the child's outcomes, and family normalization is a really great concept because my example is that we had a newly diagnosed 12-year-old who was getting ready to go to Disneyland for the first time and was actually very upset when they were they were in the hospital with newly diagnosed diabetes. So what we did was we said, it's not a good idea to go, next week to Disneyland because you're just kind of adapting to this. So we just said, like, what our goal is to make things as normal as possible, go next year, but know that, you're still going to have to manage this chronic illness. So normalization is something that I think we all should try to achieve with any kind of chronic illness. We don't want to deny the illness. We don't want to say, oh, just put it away during the time that you're in Disneyland, but really looking at how we can, try to be as normal as possible in the context of managing this illness. I think that we've all dealt with families where that child with a chronic illness is treated differently than their siblings. They have different rules, right? And that can become very challenging. A dear friend of mine just had 2 years ago, her 10-year-old was diagnosed with medulloblastoma, and his siblings are doing all the expected responses. The middle child is acting out majorly because, the child with medulloblastoma had surgery, then he had proton therapy, and it just shattered the family, really. And now they're, just trying to make sense of it. And luckily they're getting psychological help, which is great. So these are all the family aspects, and then coping strategies. My main thing is that how does the child feel about this? And the good news is, in all my research that I did, kids are like, it's no big deal. They don't view the illness as a burden. They're resilient, they're coping. And so the child adaptation is overall very good, which is good news. These other little points of the stars are social support of the child, how they perceive themselves, how long they've had the disease, if they've had depression or anxiety, and then also, their demographic factors. Because as we all know, it's a little different when you're a teenager. So the outcomes include self-perception. So how do you know if a child's doing okay? Well, how do they perceive themselves? Do they like school? Do they have friends? Are they able to function well within their family? So the tools that I've used in research have been the harder global self-worth tool. It's actually the SPPC, and it looks at global self-worth, academics, physical appearance, and social strengths. And what we found is that type 1 diabetes had very high levels of self-perception. They felt good about themselves, and they didn't feel like the illness was overwhelming. And this is a child's perspective. Children with short stature, interestingly, again, this is a physical illness or physically visible illness. They had lower levels of self-perception. And again, it's more, we think short stature is not a big deal, right? It's not doing anything horrible physiologically, but psychologically, it's tough. So the self-perception profile for children has recently been validated once again. It's been in existence for a few decades, but the reliability and the validity still remains strong. The coefficient, I'm blanking on the name of the R coefficient has been strong. R coefficient. But yeah, so recent studies show that it's reliable and valid, and factor analysis and has revealed that convergent and discriminant validity in 31 newly diagnosed kids with a variety of chronic illnesses. It's still a very strong tool. So I think the cool thing about the harder tool is that, you get a sense of how the child perceives themselves, but also you have these subdomains that, really sort out more very specific data about school and social issues. So other measures of child self-perception, there's a kid screen that measures quality of life. I mentioned this earlier. And so this is really what we want out of the children, right? I mean, when we have children with chronic illness, we want them to be happy. We want them to have a good quality of life and autonomy as much as possible, right? And eventually becoming totally independent from parents. There's also the children's attitude toward illness scale. And then I participated in a study where children who are undergoing bone marrow transplants who were in the hospital for months at a time, they actually created their own music videos. So they worked with music therapists. It was really a cool study. It was a lot of fun. And then, just the most basic self-portraits that you can do as far as, art therapy. When I was a new pediatric nurse and dealing with a child who was newly diagnosed with cancer, I remember I just got some paper from the nurse's station and I asked him to draw a picture of himself, and he had a huge needle, a syringe and a needle at the end, and then he was in the very corner, tiny little person. So, that says a lot. So even just it, and I know that strict researchers might say that it's really not a valid way to research kids' feelings, but it can be pretty dramatic what they end up coming up with. So these are just some ways that you can use multiple methods. And then, of course, qualitative interviews. So future research, I think the most important thing is asking the child how they're doing, and not, bless you, a qualitative research study that I did with kids with diabetes versus short stature. One of them said, the doctors just talk to my parents, and I'm sitting right there. So why aren't they telling me, what I need to know? And so it's really important to remember to ask them. And even the youngest children, 5 or 6, will have an opinion. So don't rely just on the adults in their life. I'm not saying not to ask them, but you should also ask the kids. And then, as I discussed before, I think that everyone with a chronic illness, how many of you know someone with a chronic illness? Yeah. Okay. So yeah, 1 in 5 persons, at least in the United States, have some sort of chronic illness. And so with any kind of chronic illness, it's important to be able to work through what that means to the person and those around them. So I'm a proponent of having psych involvement right away, right when you're diagnosed. Then you develop your coping strategies, and when you have any kind of challenges, you can go back to that person. I think that longitudinal studies eventually will reveal the predictive factors. We're still sorting some of that out. And then studies exploring differences in coping and adaptation to different chronic illnesses will also be interesting. And then, just kind of asking, is adaptation is it a process or is it an outcome? And it's been researched as an outcome, but it's obviously a process. There's all kinds of adapting and coping and shifting into different modes that you have throughout illness. And I'm from Chicago, so that's our skyline.